for next 15-20 minutes, we'll be talking on simulation, simulation, and simulation. Simulation is now going to be the buzzword now in the near future. So what is simulation? Simulation is a technique. It is not a technology. And it is a technique to replace the real life experiences or your clinical scenarios. And you basically replicate into real world in a very much, control manner. And this is Dr. David Gaba, who is the founder father of healthcare simulation. He started all the simulation activity long back, and then we have been carrying. Basically, we learned all the lesson from the aviation industry, and they have been doing simulation all this year. And now slowly now it is coming into the healthcare. According to definition, it is simulation means a model of set of problem or event that can be used to teach someone how to do something or the process of making such a model. This is typically a Cambridge dictionary, and it is a technique, as we said, that is artificially replicates real world experience into interactive manner to achieve a stated goal. So you will be hearing a lot of now simulation based education. It is coming into now medical education also, and it is based on the Cope's experiential learning theory. Now, what is it? It has got basically four fundamental components. There is a concrete experience. What is concrete experience? That is what you and me do every day. So our clinical skills, our clinical scenario, and then you basically come back and then you discuss, you have a reflective observation, and then you start thinking. So there is a critical thinking. And from this critical thinking, we learn something, and then we apply same thing in our clinical practice. So this is going to be the basic of simulation-based education. So this simulation-based medical training, you can put it into your regular curriculum, right from first MBBS to the PGs. We can train some skills like intubation, your spinal. At the same time, it provides you critical thinking. You can be very well, well-versed with, teamwork. And it is one of the assessment tool where you can actually measure the effectiveness and student progress. As I said, it will be used for the medical undergraduate students, all the PG trainees, as well as residents and the practicing physician. So it can be a formative and summative certification assessment, and it is actually more meaningful to actually demonstrate the competency rather than just doing the oral examination. And in contrast to the traditional focus only on the knowledge, simulation allows assessment of the knowledge, technical as well as non-technical skill. And we'll, in a minute, we'll discuss what are the technical and non-technical skill. So basically, what is the role of simulation in anesthesia? We can start from, foundation course. What is happening whenever the new PG trainee comes into the department? For the next 2 weeks, 3 weeks, he's just been, sort of, observing, and he's wondering, somebody's coming, putting an IV, somebody's intubating, somebody's giving relaxant, and suddenly there is a critical event, and there is a lot of, fuss and fuss, right? So basically, he's not very much comfortable. So what we thought, that this simulation can be used as a foundation course where they are the newly joined PGs. They are basically, get into the simulation lab, and they can very well get versed with the equipments, your drugs, how to mix up the drugs, how to, do the procedure, and how to follow the institutional protocol. I'll just tell you one example. When I was in my first term at KM Hospital, there was a vaginal hysterectomy, elderly lady, and madam told me, Rajendra, take mefentin, dilute it and give 1 cc. So I taken 30 milligram mefentin, diluted it, and given whole lot. What she meant, you dilute it and after that 10 dilution, you give 1 cc, right? But this is going to happen, So this simulation can be used, very well in the foundation course. And then we can have the resuscitation course actually. We can teach ACLS, basic life support, because this is the fundamental part of our anesthesia practice. So simulation based training can be conducted right from basic life support, advanced cardiac life support, ATLS, and you can become a good resuscitation team member. The next one is airway management. We basically encounter anticipated, unanticipated difficult intubation. But in that particular situation or in that particular event, we cannot teach anybody because this is a very pressure zone of that time. So we can use simulation to teach airway, unanticipated, you can teach all the skills. This is the one which, we are putting on a LMA, and this is the intubating LMA. So we can, at your leisurely, you can teach all the students from, video laryngoscope, fiber optic intubation, and at the same time, cricothyroidectomy. It can be used in the regional anesthesia also, whatever we are teaching the student on the patient actually, right? There is always a pressure of the timing. The surgeon is, they want to start early and they want to finish. There is no time for, but you can have, simulation based learning to teach regional. Now, this is, I'm giving a epidural on one of the mannequin. I'm using this new Macintosh balloon. At leisurely, you can view, and these students can then practice on the mannequin. So they can, upskill their techniques till they are happy, they are confident. At the same time, it can be used for the regional technique, your needling, your hand-eye coordination. At the same time, we can, get ultrasound and do all the technique. So simulation can be used in the regional anesthesia also. Same thing about the point of care ultrasound. This is a good mannequin called Viamedics. There is a male model, female model also available, and we can do all sort of, your fate study, your focus examination, you can do very effectively. So you get the knowledge, at the same time you get the practical skills also, and it is displayed on the big screen also. You can practice yourself. Obstetric anesthesia, you all know this is a high risk area where there are, quite a few interprofessional teams involved. Obstetrician is there, the neonatologist is there, your nursing team, your ward boy, and your anesthetic team. And this is a high pressure zone where suddenly something goes wrong and then we are basically stuck. Especially, in the intrapartum hemorrhage, the PPH, the PIH. Here you can teach all the techniques. The trainees basically they are put into the situation, and then how to behave in that situation you can actually practice. Same thing happens with the pediatric anesthesia. Pediatric anesthesia, we do not get lot of exposure every now and then. So there are sometimes, occasional pediatric. Suddenly you get a pediatric case, 1-year-old, 2-year-old. We are under pressure. So you can learn all this technique, right? From IV cannulation to the difficult airway. In neonates also, we got mannequins who's got, neonate as well as, the child. And we can all the practice the skills on this mannequin. As far as trauma is concerned, as an anesthesiologist, we do not handle trauma, every day-to-day practice. During this TLS course, we can do a proper planning and proper teaching where we can learn the primary survey, the resuscitation, the secondary survey, and the definitive care. And all these mannequins are now available, and we can conduct all these scenarios. At the same time, the simulation can be used in the intensive care situation. Something goes wrong suddenly, and then what to do next? So there are, different team involved, and we do not find, sometimes there is a lack of coordination basically. So we can do in situ simulation. So we can go to this ICU, you take one room which has not been occupied, and we can run this simulation scenario in situ, and then we can interact with the multidisciplinary action. Then there is a good team coordination. At the same time, there are challenges when you want to talk to the relatives, and then, in case of any eventuality, how to break the ice or how to break the news. We can all do that. So this is the role of simulation in anesthesia. At the same time, as an anesthetist, we encounter every day some critical events. And suddenly, if you're thrown into that situation, then what to do next? We get under pressure. We can actually create all these critical incidents which are very stressful, at the same time challenging. And there will be multidisciplinary training which is focused on non-technical skill. So it prepares the anesthesiologist for all this handling life-threatening situation. So these are type of simulation or simulators we got in the medical education. There are high fidelity simulator. These are all realistic mannequin with physiological response. What do you mean by physiological response? I'll just tell you in a minute. But we can use actors who are basically trained to perform as a patient, and this can be used for the examination, the OSCE, and all this new pattern. Now you see the virtual reality. You have been hearing now virtual reality, augmented reality now, and you can actually have a immersive environment to scale your practice. Okay, and then there are different computer-based software available. Lot of advances are going on. These are basically simple task trainer. These are half body or the upper body, and as you see on the left side, we can do video laryngoscope. And the best part of it is that there is no pressure. And you can aram se teach your trainees. They can practice on these mannequins. On the right side, you can see trauma when there was a lot of facial burns, and how to do intubation. What should be what precaution you will be taking care of in this situation. We can actually practice that. This is another mid fidelity, or you can call it high fidelity simulator, where there is a trauma patient involved. There is an amputation here, and go as real to the possible. Obviously, the leg will be covered here, These are the HPS, Human Patient Simulator. And the best part of it is that it can actually go very much in the air. Now, this is the HPS in the pediatric patient. And if you see here, there is a system or a mechanism where you can actually measure. There is a drug recognition system, and all the syringes are basically barcoded. So if you give propofol 2 cc or 3 cc, the patient will just close the eyes automatically. But if you give a good dose of 10, 12 cc's of propofol, he will go to sleep. At the same time, if you give atracurium, he will keep on breathing. After about 3.5 minutes, he will stop breathing. So it is all barcoded recognition, and you can actually go as near to the physiological situation as much possible. These are all available now around us. These are basically standard patient. Now, if you see, this is a lady who probably 60 kilograms. She can become a big, obese patient. And these actors are basically, we can have this into the examination, or we can actually create this into the simulation scenario also. This is one of the a small newborn baby. You won't be find any much difference between the real and the mannequin. But this is the mannequin, and it actually talks to you. This is a child actually, and you can do blood pressure monitoring. You can do ECG. You'll see some tracing on the neck also. You can do front of neck access. So, and everything is been controlled with the software. And now, last few, recent year, there has been, introduction of the virtual reality. Best thing about the virtual reality is that you won't need mannequin, physical mannequin. You won't need a simulation lab. We can actually create a virtual operation theater. We can actually create a virtual intensive care or maybe emergency department. What you are supposed to do is, you wear this HoloLens and you get immersed into that scenario, whichever is created. And then you can do all sort of skill, you can run all sort of activities, and you got these two joystick sort of things, and it will give you, you can do in IJV cannulation, you can do laparotomy and all those things, right? So it's very much good development in terms of simulation in medical education. At the same time, we have been using computer based scenarios. What you see in the middle is a small laptop where the scenario is loaded, and depending on what you do, there are few stages, and you can go from one stage to another depending on what the trainees are doing. On the screen here, you'll see all the vitals are displayed here, and the same vitals are then displayed on the screen of the simulator. The trainees are working there, the consultants are working there, and you can actually see what they are doing on this screen. So there are 2, 3 cameras, and depending on their response, you can change the parameters here, right? So these are all types of simulation in medical practice. If you think a total, what are the basic major components of simulation, and what is we've been doing is put into 3 groups. So this is pre-brief, the scenario, and then later on we do the debriefing. So what is pre-brief? Pre-brief means basically we just tell them, get one team where one person will be the consultant, 2 will be the senior registrar, and another 2 will be the PG training. One can become a biomedical technician, or one can become the nurse. They've been explained about their roles, the context of the scenario or the situation, and then they are basically asked to conduct the clinical case, right? There is something called as psychological safety. Psychological safety means what? They in a situation, or they are in a control situation. Even if anything goes wrong, they are not going to harm the patient. And at the same time, even if there are mistakes, that's fine. As long as you accept that it is a mistake and you get corrected, that's fine. The next phase of the simulation is the scenario, where the participants are asked to manage a clinical situation, and then there is a realistic for one of the faculty, or we call it facilitator, can get embedded as one of the participants, and then he can sort of prompt, he can guide them in case required. You can have the augmented learning. This is one of the scenario we did a couple of months back. There was an obstetric workshop, and we tell them in debriefing that this is a patient who is a 28-year-old diagnosed with PIH, and she's posted for the emergency LSAs. Labor epidural was already put, but it is not working, and she's been now OT, fetal distress is there, and then you give spinal, and the surgery will start. Let us start. I'm painting and draping. IPXis is working. Yes, ma'am. IPXis is working. After we'll make ready for the operation. Yeah, I know.
So shall I start? Can I go ahead? Yes, yes. Okay. Chalo, I'm exercising. Okay. 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 Neha, are you okay? Okay. Yeah. Incision made? Yes. No, my God. Oxygen. Okay. But then only thing impending then she had pets also, no? So that's why she had to be saturated. 1% is awesome. What's happening? What's happening? Okay, see, details were so much. Okay, our initial review was so I give something. Okay, give something. Then one time, please also you can see if there's any. Yes. Have you started the IT fluids? Yeah. Yes. Oxygen. Blood and also delivered. Okay, every check-in, IV fluids give some saline. 150 micrograms. Given Velacin. Okay. How are you feeling? Neha.
So this is how you create. This is we done one of the workshop in obstetric, and this was sort of recorded. And then after this, the participant they are after they finish the scenario, they come for the debriefing, right? All the events happen during the scenario. They are discussed, and all the participants, the one who have already done the scenario at the same time, the other participant take into the conversational part, and then we basically they will reflect what has happened, what is the description of the event, and then we can do the critical analysis if there are any strains, anything went wrong, or anything we could have done in a better way. And this is how you learn. At the same time, at the end of the debriefing, we discuss about the proper guidelines or what are our national or international protocols to follow in this situation. And these are basically we learn. But we learn all these techniques now. At the same time, the most important part of the simulation also is that we learn non-technical skill like communication, teamwork, leadership, situational awareness, and decision making. This is the most important part of the simulation because this is not been taught in our regular teaching. And unless you put into this situation, only then only you learn this non-technical skill. Just give you one example. You want to learn driving now. So you hire one of the trainer, he will teach you all the 10 lessons, and you are well versed with the driving now. And then you get a license, then you go. Suppose you go to the Aurangabad for one of the conference and it's a busy time, busy road. There is somebody, something happen on the road and you get stuck. Now that this trainer has not taught you what to do in this situation, but the simulation will tell you what is to be done next, how to get, people involved, how to communicate, how to make a decision making. So this is the base part of the simulation. And these are called anesthesia non-technical skills. So these are similar to the crisis resource management, which requires coordinated team-based strategies. And if you see, the human error are responsible for almost 80% of the all errors in medicine. And lack of the non-technical skill has been associated with adverse patient outcome in the perioperative period. So these are very important anesthesia and non-technical skill. Simulation training offers strategies for early detection of this potential crisis, and at the same time, what intervention you'd be doing, and how to approach, the team-based management. And this can be very well achieved with the simulation, with debriefing. We can actually play back the videos, and we can actually, discuss the critical event. We can stress on the task management, decision making, situation awareness, and teamwork. Another base part of the simulation is the communication skill. It serves an excellent medium for training focused communication strategies. There are sometimes difficult conversation and communication within the team, communication between the interprofessional teams, and this will give you a good chance because the quality of the communication, especially related to breaking bad news, has been found to be improved with the simulation technique. And there are this fundamental principle of the simulation, what is called as suspension of disbelief. Basically, whenever you are put into a situation or a simulation scenario, you have to believe the unbelievable, and we should not resist the judgment of the simulation authenticity. And we are getting nowadays very good high fidelity simulator. We are going as near to the possible to the real life situation. This is a Vegas rule. What happens in simulation stays in the simulation. Basically, you are actually practicing on the simulation, or you're doing a particular scenario, It happens that, if you can make a mistake, that's fine. As long as, you accept the mistake, as long as, you correct from it, because mistake are the, opportunity for learning. And here you can afford to do mistake. We cannot do a mistake in a real life situation. At the same time, there is a basic assumption that, all the participants are intelligent, capable, and we have come to improve our the technique and at the same time learn from the non-technical skill. So what are the advantage of the simulation learning? It improves patient safety. It provides safe, controlled environment where there are different situations, but you got a freedom to learn and practice without compromising patient safety. At the same time, I said about the psychological safety, it's a non-threatening zone because it focuses on the event and not on any person. You can have accessible learning opportunity. Okay, it allows scheduling. We can do it, when everybody is sort of free, not under pressure. At the same time, you do deliberate practice n number of time, and then you can get, you can become from novice to the expert. At the same time, the training program can be developed as per the requirement of the learning. We can have different program for the first year trainee, second year trainee, for the consultant. We can have have different program. At the same time, when you get detailed feedback and evaluation, okay, during the debriefing, you can have the basically you achieve the desired objective. And at the same time, the most important part is the team building. Whenever you are working in a team expert turn into a expert team. And teamwork is a major factor affecting patient outcome, especially in a critical event. So what are the challenges and limitation? Well, first is the cost. We are basically getting all this high mannequin from some companies, but the cost goes very high. And then these centers are not, they are coming up now in all the medical colleges now. But as of now, there is a limited availability. We cannot go to the 100% real life scenario. So realism can become sometime a problem. And they need to have, specialized instructors. We'll be needing a lot of, trainees or trainers in near future. So what are the future trends? Basically, the artificial intelligence is coming in a big way now. So it will have, very much impact on the decision making and the predictive analytics. We're coming up with now virtual reality, augmented reality. So it can be, more immersive, at the same time, more interactive session. You can have remote simulation also. If you got a lab in, suppose, say, Aurangabad, I can operate those simulators through the software from here. At the same time, we can have tailored simulation based for depending on the individual learning needs. So what is the way forward? So application of simulation in healthcare, especially in anesthesia, is going to expand exponentially. You believe it or not, but it's going to come in big way now, especially in anesthesia, in pediatrics, and is intensive care. And with the emerging new technology and increasing awareness, simulation will contribute to a safer anesthesia practice, leading to better patient outcome. This was one CMO in UK, and he put it into annual report that simulation training in all its form will be a vital part of building a safer healthcare system. So I'm going to end here. Just show you one of the scenario which we recorded.
Suction check, ma'am. Machine check, ma'am. You have kept ready the tubes? Yes, ma'am. Tubes are ready. Okay.
The language is in Malayalam.
Good morning. Namaste.
Namaste, ma'am.
But you will get the gist of it.
ನೋಡಿ ಕೈಯಲ್ಲಿ ಒಂದು ಸೂಜಿ ಎಕ್ಸ್ಪ್ಲೈನ್ ಮಾಡ್ತಾ ಇದ್ದೀನಿ. ಕೈಯಲ್ಲಿ ಒಂದು ಸೂಜಿ ಇದೆಯಲ್ಲ, ಅದರಿಂದ ಮತ್ ಕೊಡ್ತೀವಿ, ಇದ್ದೇ ಬರುತ್ತೆ. ಆಯ್ತಾ? ಎಕ್ಸ್ಟ್ರಾ ಆದಾಗ ಒಂದು ಬಾಯಲ್ಲಿ ಒಂದು ಟ್ಯೂಬ್ ಇರುತ್ತೆ, ಚೆನ್ನಾಗಿ ಉಸಿರಾಡಿದ್ ಕೂಡ ಅದನ್ನು ತೆಗೆದು ಸರಿನಾ? ಗಾಬರಿ ಪಡ್ಬೇಡಿ. ನೀವು ಆಪರೇಷನ್ ಆಗೋತಂಕ ನಿಮ್ ಜೊತೆ ಇರ್ತೀವಿ. ಡೋಂಟ್ ವರಿ. Yes. Okay. Yes, Pratiksha. Suction check. I'm very particular about suction, Pratiksha. Yes, ma'am. Check, ma'am, please. Check, ma'am. Okay, ma'am. Okay, you say we have kept Irka there also. Booji kept, ma'am. Elevate, idle, kept, ma'am. Right, ma'am. Elevate. Aidu. Aramagiri.
The surgical call point. Yes, sir.
Praveen. Pratiksha, taken consent, ma'am. Praveen, read the checklist.
Yes, ma'am. As the patient confirmed, these are the identity site and procedure and consent taken.
Yes.
The site is marked.
It's not applicable.
Is the anesthesia mission and medication check complete?
Yes.
Is the pulse oximeter on patient functioning?
Yes.
Any known allergies, ma'am?
No. Talk to the patient.
Difficulty of aspiration risk.
Yes.
Reason, ma'am.
MPT grade for short neck, double chin, extension limited.
Grade class more than 500 ml.
No. Done, Praveen?
Yes, ma'am. Checklist done, ma'am.
Okay, I'll engage Pratiksha. Yes, ma'am. ಆರಾಮಾಗಿ ನಿದ್ದೆ ಬರುತ್ತೆ ಆಯ್ತಾ ಬೇಡ ಡೋಸ್ ಕಂಪ್ರೆಸ್ ಇಲ್ಲ ಓಕೆ ಪ್ರವೀಣ್ ಸ್ಟಾರ್ಟಿಂಗ್ ಗಿವಿಂಗ್ ಮಿಡಾಜೋಲಮ್ 1 mg 1 mg ಮಿಡಾಜೋಲಮ್ given giving fentanyl with 100 miles if required we give afterwards 100 miles fentanyl given yes sir you start
Okay,
sir. By the time it starts
company.
I don't give glyco. We'll see afterwards, okay? Yes, ma'am. Giving propofol, ma'am? Yes, ma'am. Propofol 100 in is not under, right? I'll give Silmo. Yes, ma'am. Praveen, propofol, please.
Yes, ma'am.
Yes, Praveen. Giving another 30 extra. Yes, ma'am. Ma'am, is under? Is under, ma'am. Okay. Able to ventilate? Yes, ma'am. Able to ventilate, ma'am. Okay, Pratisha? Yes, ma'am. Able to ventilate, ma'am. Yeah. Giving bacterium? Yes, ma'am. 8 mg? When 8 mg in? Yes, ma'am. Timer on, ma'am? Yes. Fluid, I put RL, okay? Okay. Yeah. Ready? For the intubation? Yeah.
Senior staff manager, ma'am. Senior staff manager.
Dr. Rajendra Patil ಇದ್ದಾರೆ ಸರ್. ಇದ್ದಾರೆ ಸರ್.
Okay.
See on. Maintain a mat. Yes, ma'am. You want some assistant? Yeah. Ventilating? Yes, ma'am. 3 minutes over? Over, ma'am. Yes? Praveen, ready?
Yes, ma'am. Very much.
With a blade 4?
Yes, sir.
Yes?
Thanks.
Anaesthesia, Pratiksha? Ma'am, ಏನು ಕಾಣಿಸ್ತಿಲ್ಲ. I cannot see anything, ma'am. Give. Ma'am, one more chance, ma'am, please, ma'am. Yeah.
Sir, ma'am, ಅಲ್ಲೆಲ್ಲ ಮೊದಲ ಬಿಟ್ಟರೆ ಆಮೇಲೆ ಅವರು ಪೇಷಂಟ್ ಕೊಡ್ತಾರೆ.
Oh, it's so difficult. Call Rajendra Patil. Calling staff, ma'am? Yeah, I can't. Sir, call for help.
ಯಾವಾಗ ಹಿಂಗೆ ಒಂದು ಇಂಟರ್ವ್ಯೂಷನ್ ಮಾಡಲ್ಲ.
Sir, ತುಂಬಾ ಕಷ್ಟ ಇರ್ತೀರಿ. ಕಾಣಿಸ್ತಾನೆ ಇಲ್ಲ. ಬೂಟಿ ಸರ್?
ಹಂಗೆ ಹಾಕ್ಬೋದು ದಯಮಾಡಿ ಅಷ್ಟೇ BP ಕಡಿಮೆ ಆಗ್ತಿದೆ ನೋಡ್ರಿ.
Sir, don't worry, we'll take care.
ಇದು
Once every second we'll take care. Yeah.
inflate.
Yes, sir. Fluid rushing, ma'am. Connect, Praveen.
Fluid ಕೊಡಿ.
Fluid rushing, ma'am. Yeah.
BP ಕಡಿಮೆ ಆಗ್ತಿದೆ, fluid ಕೊಡಿ.
400, 500.
ಚೆಕ್ ಮಾಡೋಣ.
Yes, sir.
ಚೆಕ್ ಮಾಡಿ ಹಾಸ್ಪಿಟಲ್ ಮಾಡಿ. Yes, moving. ಎಷ್ಟು ಬರ್ತಾ ಇದೆ? ಸ್ಯಾಚುರೇಷನ್ ಇಂಪ್ರೂವ್ ಆಗ್ತಾ ಇದೆ.
Bilateral equal, sir.
Yes, fluid ಸ್ವಲ್ಪ ಟಚ್ ಮಾಡಿ. Yes. Yes, super. ಬರ್ತಾ ಇದೆ. ಓಕೆ. ಅಸಲ ವಾಶ್ ಮಾಡ್ಕೊಳ್ಳಲ್ಲ? ವಾಶ್ ಮಾಡಿ. ಫಿಕ್ಸ್ ಮಾಡಿ.
Fix at 20. Yes, ma'am.
ಓಕೆ.
Sir, right step ಅಂತ?
ರೈಸ್ ಹಾಕ್ಬಿಡಿ ಬಾ ಈಗ. ಅಸಲ ನೀವೇ ಸ್ವಲ್ಪ ಹಾಕ್ಬಿಡ್ರಿ. ಅದೇನೋ ಡಿಫಿಕಲ್ಟ್ ಇದೆ. ATC HOD is coming. Yes, good confirmation. Square wave form. ಎಲ್ಲ ATC HOD ಇದೆ ಬರ್ತಾ ಇದೆ. ವೆಂಟಿಲೇಟ್ ಆಗ್ತಾ ಇದೆ. ಓಕೆ. ಸರ್ಜಿಕಲ್
This was in short about the simulation. The idea is to sensitize all of you. You will be hear more and more of simulation in near future. Thank you very much.